Welcome to Integrative Medicine Grand Rounds. My name is Hélène Langevin. I'm the director of the Osher Center for Integrative Medicine, and I am delighted to introduce today's speakers for Integrative Medicine Grand Rounds that are from the Center for Metabolic Health and Bariatric Surgery at the Brigham. So today, we're very, very pleased with welcoming the Center for Metabolic Health and Bariatric Surgery because it's a little bit different from what we've experienced so far in these grand rounds. So far, we've had centers that are actual centers for integrative medicine that have presented in turn every month. And this is a little bit different because this particular group is not nominally a center for integrative medicine, although, as you will find out, they really are doing integrative medicine. And the way this happened is that actually Dr. Paul Davidson, who is going to be one of the speakers, contacted us and said, we'd love to present at your grand rounds because we really do integrative medicine. And we were actually really thrilled to say yes, of course. And I want to just read to you the definition of integrative medicine as is on the website of the Consortium of Academic Centers for Integrative Medicine. And it goes like this. Integrative medicine and health reaffirms the importance of the relationship between practitioner and patient, focuses on the whole person, is informed by evidence, and makes use of all appropriate therapeutic and lifestyle approaches, healthcare professionals, and disciplines to achieve optimal health and healing. And I hope that you will agree with me that today's presentation is going to meet that definition. So I will first introduce Dr. Paul Davidson, who is going to be introducing the first speaker. He's the Director of Behavioral Services at the Center for Metabolic Health and Bariatric Surgery at the Brigham.
Thank you so much for coming. Oops. Okay, there we go. We're delighted to be here. I very naively read some emails about the Grand Rounds presentations by the Osher Center and talking about integrated medicine and not realizing at that time you were really talking about east-west integration and complementary health. So I sent an email off to my colleague naively saying, hey, we do integrated medicine, and she very kindly was willing to meet with me and talk and came to realize, yes, this is a wonderful example of how different specialties in medicine can come together to treat the whole person. Mindfulness, as you'll find out, is certainly a very integral part of everything that we do, and I'm absolutely thrilled that we have a patient with us here today, and he's brought his wife. So you get a very fine sense of what we do, how we do it, how we work together with every single patient we see. I'm going to start off with Kellene Isom, who is the program manager for the bariatric program. She is a senior bariatric dietitian and actually is nationally renowned for the work she does in nutrition, especially in the bariatric space. So Kellene, please.
Good morning, everyone, and thank you, Paul, for the introductions. My colleagues and I are going to present a case on a patient, but before we do so, we wanted to share with you some information about bariatric surgery and also give you a little introduction to the services that we offer at our center. But first, we have nothing to declare. So why surgery as opposed to non-surgical treatments for weight loss? Well, since the 1991 NIH Consensus Conference, bariatric surgery has been considered a safe and effective approach for weight loss, and it results in an improvement in comorbidities, some immediate, like we've seen with type 2 diabetes. And compared to non-surgical options, we have seen sustained weight loss that we don't see with typical diet and exercise. Patients are encouraged to go to a facility that is accredited by the Metabolic and Bariatric Surgery Accreditation and Quality Improvement Program, otherwise known as MBSAQIP. Say that 3 times fast if you can. And I'll talk a little bit more about that as well. In 2014, nationally, we performed about 193,000 surgeries. In 2009, we had a high of 220,000 procedures performed nationally, but you see this high 100,000 level for the number of procedures performed each year. Now, in 1991, the criteria for having bariatric surgery was to have a patient who had a BMI, body mass index, of 40 or above, or you could have a patient with a body mass index of 35 and higher with comorbidities like our type 2 diabetes, sleep apnea, high blood pressure. And in addition, you wanted to have a prepared patient, someone who had tried to lose weight non-surgically, someone who was mentally stable, someone who had a great support system and was motivated, and also not dependent on any alcohol or drugs. In 2004, two organizations, the American College of Surgeons and the American Society of Metabolic and Bariatric Surgery, each created their own Center of Excellence requirements. So this was an attempt to create standards for bariatric surgery programs. In 2013, these two organizations combined to create this MBSAQIP accreditation. And Brigham and Women's Faulkner Hospital are both considered adult comprehensive accredited programs by MBSAQIP. So MBSAQIP is the program that institutes standards and certain requirements for us as centers of excellence so that we have the right equipment for our patients of size, so that we have the right clinicians and a multidisciplinary approach to long-term care after surgery. So as far as the multidisciplinary team is concerned, they're involved in the preoperative assessment and the postoperative assessment. So it does start with the support of the primary care provider, but we have the involvement of the dietitian, the psychologist or psychiatrist, and the surgeon in the preoperative assessment. All of our patients who go through our program first attend an information session where they learn about surgery. And this is a non-commitment session so that they can learn about the risks and benefits of the procedures and meet with our team, as well as understand the lifelong commitment that's necessary on their part in working with us. After a patient is interested in surgery, they're scheduled for a surgical consultation, 2 appointments with nutrition and psychology assessments, and then they have preoperative follow-up from there based off of their individual needs. They have other appointments depending on their past medical history, such as upper GIs or possibly need for cardiac eval and sleep studies. And then any other requirements dependent on their insurance. Postoperatively, we do work with our patients long term. We encourage our patients to follow up for life. They meet with the surgeon and the dietitian a few weeks after surgery, 6 weeks, 3 months, 6 months, 9 months, and annually, as well as 18 months, 24 months. So we are seeing our patients regularly. They're also encouraged to follow up with our psychologist, Dr. Davidson, and see him as much as they can after surgery. Typically, we recommend 6 weeks and 6 months postoperatively. But all our patients are provided with lifelong care and unlimited nutrition visits, so to help with mindful eating and lifelong healthy eating. So now Dr. Tavakkoli is going to discuss some of the procedures that we offer and also introduce you to our case. Dr. Tavakkoli is one of our bariatric dietitians, and he's also the co-director. Oh, did I say dietitian? Look at that. Look what you started, Paul. He's an honorary dietitian, but he's one of our bariatric surgeons. And he's also the co-director for the Center for Weight Management and Metabolic Surgery as well here at Brigham.
I guess I am a dietitian because I do alter diet. So that's so thanks for having me. I wanted to thank everyone, and in particular Sean and his wife, for coming here today to kind of highlight this program that we've offer at the Brigham. So my role is to talk about the surgical procedures first, but I actually wanted to start off with this picture, and this is a picture of the human body and the different organs that are adversely affected by obesity and weight. And as you can see, pretty much nothing is spared. So obesity is a major problem that affects every pretty much organ in the body, and as a result, an individual who's obese has a life expectancy that's shortened by 8 years. So that's equivalent to being a heavy smoker lifelong. And when bariatric surgery started, our initial metric of success was weight loss. So we would really focus on how much weight people lose. But nowadays, there's been a real shift in the field, and we're actually increasingly interested not only in a reduction in weight, but also by how much does the patient's overall health improves. And I think hopefully Sean's case will kind of highlight this. And in particular, the comorbidities that have caught a lot of attention has been the rapid resolution in diabetes, hypertension, and sleep apnea that's seen after the surgical operations that are performed. So what surgeries do we perform? And there are essentially three main operations that are performed at the Brigham and nationally. And all of them are based on altering the GI anatomy. So this is what the normal anatomy for most of us looks like in this room. So when we eat, the food comes down through the esophagus and enters the stomach, which is essentially a floppy bag that stores food. And that food is slowly released from the stomach into the small bowel where the nutrients are absorbed. So one of the operations that we used to perform very commonly was the lap band procedure. This was a laparoscopic procedure where we performed and we placed a silicone ring along the upper part of the stomach. This ring was then attached via tubing to a port that was placed underneath the skin, usually on the right side. And then starting 6 weeks after surgery, we used to put a needle that went through the skin into the port, injected saline that went through the tubing to this ring, and essentially tightened the ring. And the way we thought it works is that it restricted the amount of food that went through the stomach, effectively creating a smaller stomach above it, and reduced food intake led to weight loss. It was a very popular operation, so until about 4 or 5 years ago, about 40% of the bariatric surgeries that we performed at the Brigham and nationally in the US was the lap band. And the issue was that although some patients did well and lost about 40% of the extra weight that they had, the long-term result, it turned out, was not so good, and a lot of people struggled with weight regain, inadequate weight loss, or had problems related to this device. And about 30% or so ended up having the band removed because of these complications. As a result, this procedure has gone very rapidly down in popularity. And nowadays, probably less than 1 to 2% of the bariatric procedures that are performed at the Brigham or nationally are actually consist of this. The surgery that has in effect kind of replaced the lap band has been the sleeve gastrectomy. So this is a laparoscopic procedure where we make 5 to 6 small incisions in the upper part of the abdomen, go in, and we essentially remove about 70 to 80% of the stomach. And that stomach that, as you can remember, used to be here, is removed completely, leaving behind a stomach that looks like and is about the size of a banana. This surgery takes about an hour to perform. Patients are typically in hospital for 2 nights, and then they'll go home, and Katy is going to talk about what the diet is like after these surgeries. And although initial concept was that this surgery also works by restricting the food you can take, because now you have a much smaller stomach, the reality is that there are significant hormonal changes that occur after surgery. And what happens, actually, patients' hunger disappears. So I think it's important to realize that this surgery doesn't work because people are hungry, but they just can't physically fit any more food into the stomach. The real big life-changing event is that the hunger goes away, so they just don't feel hungry. Now, another operation, which is kind of regarded as the gold standard operation for us, has been the gastric bypass surgery. So this surgery we've been performing in one form and another for about 30, 40 years. In fact, it's going to be the 50th year of the first gastric bypass next year. So it's been around for a long time. And what this operation does, and I'm going to have a little animated video to show, is actually creates the small stomach, which is about the size of an egg, and also by cutting the bowel, bring it up and suturing it here, we're bypassing the stomach and the first part of the intestine. This surgery takes about an hour and a half to 2 hours to perform. patients after surgery in hospital again for 2 nights, and they have a similar dietary progression, as Katy will talk about, than to the gastric sleeve. This is the most complex of the operations we perform, and as a result, the effect on weight loss tends to be more, so people lose more weight after this surgery compared to the sleeve. So people lose 60 to 70% of the extra weight that they have. And also it has the best outcomes in terms of the anti-diabetic effects of the surgery. This is the surgery that Sean had, and I think we're going to talk about that in a second. So I just wanted to show a little. So this is how we perform gastric bypass surgery. It used to be done as an open surgery. Nowadays, pretty much we never do it as an open intervention. It's done laparoscopically, so we place 5 to 6 incisions, small incision, introduce ports and cameras through those, and that allows us to visualize the inside the stomach. We start by stapling the stomach to create the new stomach that I mentioned, which is about the size of an egg, so 30 cc's. We then come down, identify the small bowel and divide it, as you can see here, and bring this segment up and suture it to the stomach. So as a result, after surgery, when people come, they eat, food enters the stomach and then travels down, and in doing so, we're bypassing the stomach and the first part of the intestine. So I met Sean in December of 2013, so it's coming up to just under 2 years now. At the time, he was a 40-year-old, lovely guy, married with a wonderful wife and 2 kids. And I think, and he'll talk about it, one of his big issues was that he was a young man, but he'd been diabetic for 11 years. And we know diabetes is now the commonest cause of blindness, renal failure, and amputation in the US. Despite all these new medications we have, treatment and management is suboptimal. And he was really interested in not just losing weight, but also improving his health. He also had hypertension, hypercholesterolemia, he had sleep apnea and used the CPAP machine. And he also had a strong family history of coronary artery disease and the comorbidities. And he came to us seeking help. And I think I'm going to stop at that point, hand it over to Katy, who is one of our experienced senior surgeons, dietitians, and she'll talk about how the pre-op evaluation went.
Hi everyone, and thank you for having me today. I'm going to go through what the dietitian's role is in caring for patients that are pre-op bariatric surgery and post-op bariatric surgery. So as Kellene mentioned, any patient that desires to have surgery does need to come in for a group nutrition class. So this is a class that I've been teaching since I've worked here. Some of the main concepts we start out with in this class are our skills for success. And these are lifestyle changes we want the patients to start working on before surgery. That way those healthy habits can transfer over to after surgery. So we review that surgery is a tool. And it's going to be an excellent tool to help patients achieve their goals, but the tool needs to be used effectively. So we always start out the class by really honing in on that aspect of surgery. Then we discuss a pre-op diet that patients will go on about 2 weeks before surgery in order to shrink their liver. We'll review our post-op diet guidelines. We really have a lot of emphasis on mindfulness after surgery because it does prevent, to an extent, post-op intolerances, nausea, vomiting, and other issues that can occur. In this class, we give every patient a homework packet, which includes a 3-day food log and a nutrition quiz. And our purpose of doing this is kind of so they can prove to us that they're willing to work on something for us. They're committed to filling out the food log, answering the questions on the quiz so we can assess their knowledge, and it really just gives us great talking points for when they bring that back. So Sean did attend this class in December 2013. Once the class is completed, our patients come back in for a one-on-one nutrition appointment. So that's when the dietitian really gets to know that person individually. What are their eating behaviors? What are their patterns? What foods are triggers for them? What are the barriers that they might have before and after surgery, and how can we address them individually? At this appointment, we will review their food log where we can really see trends in what they're eating. And I like to involve the patient in kind of looking at the food log and them picking out, well, what are some good things I'm doing and where is there room for improvement? And I think when you engage the patient in that process, they're more likely to follow recommendations or goals. Also at this nutrition assessment, we go through some preoperative goals. So these are goals that our team has written out for the patient, but there's also blank so they can write in their own goals. This is my goal in terms of physical activity. For Sean, it's, running a 5K. So these are things they can write down before surgery, which makes them accountable because then they know what they're working towards. This is a snapshot of the 12-question quiz we give them, and it's really just to create talking points, make sure they're going into surgery as prepared as possible nutritionally. Once that's done, we make some permanent goals. We write them down so the patient knows what they're working on, and the dietitian communicates to the team whether or not they think the patient is ready to move forward. If they're not quite ready to move forward, we will see them again before surgery. And this is to make sure they're making progress on what we had discussed, troubleshoot any issues that may come up, review all of the diets and protein shakes and vitamins one more time before surgery, and answer any questions. I think our patients are fortunate in our program because they have a lot of support nutritionally. They're able to contact us through the Patient Gateway portal. We have a dietitian hotline that they can call Monday through Friday. We also have a secret Facebook group where they can ask us nutrition questions pretty much 7 days a week. So we try to be as supportive as we can in this process. So for Sean, his nutrition assessment was in December of 2013. Something that was impressive with Sean is that he had already been working with dietitians before coming to us. So they weren't bariatric surgery dietitians, but other dietitians within Brigham, which shows his commitment to really trying to lose weight in a natural or more medical way before turning to surgery. He had done Weight Watchers as well. In terms of his weight history, he just struggled with I cannot get below 300 pounds. So he was working out, he was walking 2 miles a day with his commute, he was working with a dietitian, but couldn't break that number, and that's why he came to us. In terms of his eating behaviors, Sean was able to note that maybe he ate because he was bored sometimes, maybe he ate because of availability of food, which I think we can all relate to, especially in this environment that we live in. And one of the questions we always ask our patients is, what do they perceive as the diet factors that have contributed to their weight? Obviously, we know there's a genetic component, and it's very multifactorial, but is there anything that you think might have contributed? And Sean said, yeah, bigger portions, maybe eating too fast, and eating food because it's there. And those are all common things that we see in our field. We reviewed Sean's food logs, and he was eating 3 meals a day and 1 to 2 snacks, which is a very structured pattern that we like to see. Portions were a little bit larger than we recommend, which is normal for somebody that hasn't had surgery yet. Sean was very impressive because he was already making changes. So before we even said, you need to do X, Y, and Z, Sean already came in with a list of things he was working on. He was eating off smaller plates at home. He was eating slower. He was cutting back on the snacks, so he was really mindful in the fact that he had thought about changes he needed to make before even pursuing surgery. So because of that, Sean was cleared by nutrition at the end of his nutrition assessment, and he didn't have any other follow-ups before surgery. So as Kellene mentioned, we have lifelong support for our patients. We see them 6 times in the first year after surgery to really make sure everything is going as planned and to really make sure the patient feels supported in this. So in our early postoperative appointments, what we talk about is pretty structured. Right after surgery, they have to follow a very specific diet, and this is to promote healing, maintain their lean body mass while they're rapidly losing weight, prevent any GI upset. So it's a very specific texture-driven diet stage they have to follow. So after surgery, patients are on clear liquids for the first day in the hospital. They then transition to protein shakes, and they'll drink protein shakes and fluids for 2 weeks. So there's no solid food in that 2-week period after surgery. They then transition to soft foods, which they'll follow for 4 weeks. And finally, around 6 weeks, they're on our stage 4, which is our regular textured diet. So at the beginning, we're really just walking them through all of these stages. In terms of mindfulness, we say chew 22 because it's catchy. Dr. Davidson will say chew 40. So it depends. I think it depends on the food. Some need to be chewed more than others. But this really causes the patient to slow down, and it prevents them from swallowing a big chunk of food that's going to be hard to digest when their stomach is, only the size of an egg. Allowing at least 30 minutes for meals, sometimes up to 40. And really obeying your stomach. We do teach patients that they have to stop when they're full. Sometimes people can get very caught up with our recommendations for protein or fluid. I have to get this amount. I have to push it and push it. But we really want them to know, we want you to do the best that you can, but you need to obey your new stomach and, relearn fullness cues after surgery. Patients are expected to take vitamins for life, so that's something that we review at every appointment as well, so we can prevent any micronutrient deficiencies that could occur from the alterations in the anatomy and also due to the lower PO intake. If you're not eating as much food, you're not getting as many natural vitamins from your food. So that's what we would generally cover in the early post-op appointments. Later post-op appointments are variable. At this point, they're eating regular textures. Our general healthy bariatric diet is a pretty balanced diet, but there really is a greater emphasis on protein. We do recommend a certain way that the patients eat around the plate. So we always say eat your protein first, then eat your vegetables, and if you're not full, you can have a small portion of starch. But what we found from experience is that if you put all your food groups on the plate and you start with starch, like pasta or rice or potatoes, you're going to get full very quickly. Remember, his stomach is the size of an egg. So if he's going to get full after just finishing the starch, he's not going to get the protein that he needs to maintain his lean body mass. He's not going to get the fiber from the vegetables. So we do teach a very specific way of eating around the plate. So at these later post-op appointments, there's various issues we could be talking about: meal preparation, eating out in restaurants, social settings. How do you deal with those dynamics after you've had such a huge life change? And if and when hunger does resurface, and this can happen, over the course of a year, it's different for everyone. Usually doesn't come back as full force as your hunger might have been before surgery, but it can creep back in at times. Some patients also have head hunger or emotional, triggers to eating. So we'll discuss all of that in the later post-op appointments. These are some screenshots of nutrition tools that we use with our patients. So on the left is the plate that I had mentioned. We have the protein that we want them to eat first, then their non-starchy vegetables, and any whole grains or starchy vegetables would be the last thing eaten on the plate if they get to that point. On the right, we have our stage 4 meal plan, and this just gives patients a little bit more of an idea of how much they should be eating from different food groups. This is the exchange system, or as I like to call it, the checkbox system. And basically, we teach our patients that when they have a serving of food, they check off the box. And once that allotment is gone, they're good for the day. So I think our patients do like using it. It's an easy way rather than counting calories. They can just kind of look at the overall picture of the diet as a whole. So for Sean, I'm just going to briefly touch on some of his nutrition appointments he had after surgery. So he did come in 13 days after surgery, and he said, "I feel great. This has been so easy for me so far." So that's something we like to hear. Not everybody says that, but fortunately, Sean was doing very well on his protein shakes, and his weight was already dropping pretty rapidly at that point. He then came in at 7 weeks post-op, and he said, "I've become an involuntary vegetarian." Now, this is not unheard of in the bariatric surgery world. When you are early out from post-op, that's when we see more of the intolerances towards protein foods. Generally gets better over time, but this wasn't something that was surprising. So for Sean, he was having a protein-focused diet, but his protein sources were more Greek yogurt and the veggie burgers and things that were not poultry. And he was taking his vitamins as we asked. He then came back for his 3-month appointment. Weight is continuing to go down in a nice manner. He's meeting his fluid goals. Diet continues to be very protein-focused, but finally, after about 3 months, he can add in small amounts of fruits and vegetables. So that's generally what we see. The farther out they get, the more variety they can add into the diet. But it's hard to have fruits and vegetables when you're 2 months out and you're getting so full off the protein. But he was able to start adding those in around 3 months, which was great. Sean also became an avid walker. He got his Fitbit. He was walking 6 to 7 miles a day. He was weightlifting, using resistance bands, so doing more physical activity than he had probably done in his whole life. So that's really nice to see. Then he comes back for a 6-month post-op appointment. His intolerance to poultry was improving, and now he was having more of an issue with beef and pork. And then at this point, he started biking and training for a 5K, which he's completing in September. So that's very exciting. So you can see as the months are going on, he's really amping up his exercise routine as well. And at the 6-month appointment, he had reported he was able to finally add in a small amount of starch. So you can see it went from kind of a protein diet, protein and vegetables, and finally able to add in small amounts of healthy carbohydrates, which he's going to need for his exercise routine. And then he comes in at 9 months, 12 months, 18 months, continuing to excel. And this is where we left off with him in August. And at this point, his weight had gone up a few pounds, and that's something I want to mention because it's not unheard of. A lot of times patients reach their lowest weight and might have about a 5 or 10 pound weight gain just as their body's kind of getting settled of where it wants to maintain. And that's where we leave off today with Sean. So now I'm going to introduce Dr. Paul Davidson, who you've already met, Director of Behavioral Services, to walk us through the psychological component of surgery.
Thanks so much again. It really is a pleasure. I do want to say that when I first came to the Brigham, I believe the Center for Metabolic and Bariatric Surgery is probably the first surgical program to hire a full-time clinical psychologist, which to me spoke to the beginnings of trying to integrate mind and body. I'd been at other programs where they had been doing that much longer, so the Brigham's a bit behind, but we're catching up. So when we take a look at what's going on with our individuals, as you've seen, they have a medical workup, and another piece that we talk about is our physician assistant, who plays a very key role as well. They see nutrition, surgery, medicine, and then they see psych. It really is taking a look at 360 degrees of the individual. So we're trying to assess, first of all, is this individual appropriate for surgery? So these are a number of the areas that we're focusing on. History, eating issues, cognition, comprehension. The comprehension is a big piece because this surgery is unlike most other surgeries in that the surgery itself is absolutely critical. It's what I would say necessary but not sufficient. So the surgery gets you to a place where you can start to excel, but nothing's going to happen unless you change your behavior. And we have to make sure people can make those changes over time. We look for issues of substance abuse, personality, and so on. We rule out those who may be inappropriate, and I'll give you a slide in a minute to show what usually would be considered inappropriate for the surgery, help figure out the timing, because some people just come readier than others, and some people really need more time to prepare, and we'll give them whatever time they need. I talk about issues of anxiety on a very regular basis, because for many individuals, this may be the first surgery they've ever had in their life, or somebody who may have had other surgeries, may have had bad experiences, and they're nervous about approaching this. So we have to deal with those kinds of things and provide a lot of psychoeducation about what they are going to be anticipating. We get an opportunity to really take a look at potential psychological issues that the person comes in with. The creation of a therapeutic alliance is critical. I'm going to be working with these people for years and years and years and years. So we want to start to develop that working alliance, deal with issues of motivation for change. Everybody comes for a different reason, and hopefully Sean will say a little bit about why he chose to come. And then we try to amplify that and then set up the expectations for follow-up, because it's really through follow-up that you're going to have the best results. And taking a look at data, one of the best studies to take a look at psychiatric contraindications, we see that really substance use disorders is the #1 reason somebody may be disqualified for the surgery, and we wouldn't approach it until they had been clean for a while. Active eating disorders, psychosis, depressive disorders, and suicidality. And personally, I think in our program, a factor winds up being significant personality disorders. If somebody has a real hard time getting along with anybody in our program, that's usually a warning sign that they may not be best for us. Some of the things for somebody to consider this surgery is, #1, I emphasize that this is hard work for life. The popular myth is that surgery is the easy way out, and as I tell people, it couldn't be farther from the truth. You do this surgery, there is no turning back. And unless you stick with things day in, day out, the weight is going to come back. And patients really need to understand that. And those who have a good grasp of it, and I can tell you Sean had a great grasp of it, these folks do really well over time. Self-blame and guilt, these are big issues. Most people who come in and are of size feel tremendously guilty about the fact they carry the weight. And so a big part of this is helping them to understand that there are other factors at work, and that genetics and environment play a significant role, and that if we can help biologically with some of those factors, it gives them a fair chance to lose the weight, because most of the people we see, they've lost weight before. They've been successful with that. However, it keeps coming back, and there are many reasons why, but hormones are key. Helping them, many folks have to lose a bit of weight prior to surgery to make it a bit safer and to shrink the liver. We have to get people off of nicotine. I would imagine that if you really went through our patient roles, we contribute mightily to smoking cessation in the hospital, because we will not do surgery with anybody who has any dependence on nicotine. So we work on that very actively. And again, we focus on the importance of behavior change. I think this sums up a lot of the resistance that I see. I don't know if you can see it. How much longer do I have before I have to change to a healthy lifestyle? So if we talk about mindfulness and weight loss, I tried to find the most recent review study. It was published recently in Psychosomatic Medicine. If you take a look, there are many studies that do mention mindfulness. However, if you really want to take a look at well-controlled studies, there are only about 19 that show up that train people in mindfulness techniques and then try to see what happens. 13 of those were randomized control studies. 12 journals, 7 dissertations. Again, it gives you a sense of how little research there really is in the area. And only a little more than half of them used any measure of mindfulness to get a sense as to whether or not there has been a change in mindfulness over time. Most of the studies do show significant weight loss. However, it's been impossible to show a clear link between the mindfulness strategies and the weight loss, because every single one of these programs teaches mindfulness, but they also teach nutrition, they teach exercise, they teach a variety of different things, and it's been impossible thus far to tease out the mindfulness component, so this may be something we're going to have to look at some point. When we talk about bariatric patients, mindful eating is everything. So I think Katy has already addressed a great deal of this. There are a lot of problems that can result if you're not eating in a careful way. So we talk about small bites and chewing. And the reason I do say we chew 40 times is because there's research evidence that tells us that if you chew your food 40 times, it actually shifts the hormones in your gut. So if any of you want to lose a little bit of weight, start chewing a lot more. Your hunger hormones start to decline, and the satiety hormones start to increase. That's a good deal. You will be satisfied with less. Slowing down, and there are a variety of strategies we teach people to slow down, including using chopsticks and toddler-sized silverware. Learning to plan ahead. It's all about thinking ahead, planning ahead for meals and shopping, and focusing on eating when eating. So many of the folks we see sit down to eat in front of the television. I'm sure none of you do that because you all look wonderful, but maybe once in a while, some of you have. It makes a big difference. You need to learn to focus, and the goal is really to enjoy eating for the sake of eating, and to be in that moment and to really sense the taste and the textures and the smells. It's so rare in our day that we take the time out to really be in that moment, and we really focus hard on trying to get our folks to be there. Eating at the table, planning ahead, recognizing emotions so you don't become an emotional eater. There are a variety of different behavioral issues that almost every single one of our patients face at one point. They tend to become more noticeable. When you are large, you tend to want to blend in, and if you're you look at family photos, most of our patients will be found either taking the picture or in the very back of the photo, so you just see the head. In our group picture, you notice Dr. Tavakkoli was in the back. You just saw his head. Very typical. One of the things we see, too, is that personal space. When somebody's large, or you're homeless, or you have psychiatric illness, people tend to give you more space. They stay farther away from you. So as you lose weight, you find people will find you more approachable and come closer. It sounds wonderful in many ways. For some people, that's a real stress, and we can talk about that with trauma. I say the mind lags the body. These changes happen so rapidly, and Sean's a great example of this. It takes a while for you to truly appreciate what happens, so we have strategies to deal with that. And we see changes in how you define yourself and start to think about new functional abilities. And, I say people become less likely to settle. So it's not just about the weight loss and getting rid of the diabetes and so on. It's really about starting to become more fulfilled in your life. And that affects relationships, sometimes positively, sometimes negatively. It affects job performance and other areas. Rapid changes lead to changes in physical activity and increased enjoyment in that. Clothing. Excess skin becomes an issue for discussion, in which people feel they're happy that they're getting smaller, but they see excess skin, and that becomes a real stressor. We deal with that. Again, relational issues I mentioned. I just want to come back to this loss of safety and size, history of sexual trauma. Many of the individuals that I wind up seeing have history of some form of sexual abuse, rape, molestation. And for them, weight winds up becoming a safety factor. If you are larger, you are less likely to be a target. And so losing that weight and getting healthier puts some of these folks at more of a sense of risk. Sometimes when people have been large and they haven't engaged in relationships as much, they get smaller, they get healthier, they want to try out their new body, and so promiscuity can become an issue. So there are a lot of things we have to deal with. Then issues of substance abuse, especially alcohol abuse, become problems. The kind of techniques that I'm using on a regular basis, meditation all the time. Deep breathing is the go-to strategy. Most of these folks have issues with anxiety, and deep breathing is a wonderful technique. Guided imagery used as well. Yesterday I had a woman who has a history of medical trauma. She had very, very bad throat cancer and had a series of very significant surgeries, and she has a hard time, so we were doing a guided imagery around being on a beach in the Bahamas. Progressive muscle relaxation, physical centering too. A lot of times I recommend yoga or Tai Chi for folks. Sometimes for those who also have attentional issues, we look at martial arts. So with Sean, we know quite a bit about him. Started becoming overweight in 6th grade. In college, he was more active in sports involved. After graduation, activity decreases, which is very typical for what we see, especially in men. He has no eating disorder behavior. He was a bit of a night eater, though. He would snack a lot in the evening, quite late. He said he was a Diet Coke junkie, large portions, and he was able to use Weight Watch as a way to lose a little bit of weight. These are the before pictures for Sean and his family. His lovely wife, Tracy, is here with us today. We appreciate them being here. Key reason for wanting to do the surgery is to be around for his young children. He's very successful. He got a Bachelor's of Fine Arts. He was married at the time 6.5 years, young kids, and is a graphic designer at a firm you all would know the name of. No psych history whatsoever. Clean. That's the thing. And if you look on the bottom, no contraindications. Very good candidate. For me, that's how I put it when I think somebody's really going to do well. And sure enough, Katy started to mention some of these, but within 6 weeks, he's already pleased. Things are happening in a wonderful way. He's walking a lot. His wife has been supportive. She's starting to change her eating habits as well, which is what we see on a regular basis, getting great feedback from others. 6 months later, he's starting to have an easier time eating. He's walking a ton. He's chewing a lot. He's doing everything. Mood is wonderful. And now he finds that his little kids are eating more than he does. He's also starting to stand out at work for his weight loss and increased health. A year out, he's about 100 pounds down. This is an amazing thing. He's gone from a size 48 in his pants down to a 36. I hate it when my patients look much better than me, but this is one of those cases. The kids are now following the eating habits. The whole family is getting healthier. We talk about integration of us, but it's also integration of the whole family. And we start encouraging him to seek bigger goals, and he decides he wants to run a 5K, wants to seek job changes with more responsibility. And our last appointment, which was last month, he now weighs 222 pounds, down from 316, BMI from 51 to 35. All of his comorbidities are gone. In addition to that, he's working out, he's developing muscle, mood's wonderful, and his wife, Tracy, he recently celebrated his 42nd birthday. She reversed the candles on the cake to 24 because she thought that was more, telling of where he was at now, that he was like a young man again. He recently received a major award at work, and he can tell you about that, and he's now seeking greater responsibilities. These are the after pictures, and I want to leave you with one quick thought. Though no one can go back and make a brand new start, anyone can start from now and make a brand new ending. So I want to invite up Sean, who is a wonderful patient, and Tracy, if you'd like to come, you are more than welcome to join. Please.
Hi. Dr. Davidson very intuitively did not tell me I was speaking until 10 minutes before I arrived. So this was a shock to me, but I've done a little bit of public speaking, so I should be able to muddle through it. For me, this was a pretty easy solution for me. I came 2 years ago to the informational in December, and I met with Malcolm, Dr. Robertson. And through that, my sister and I both decided we were going to do the surgery. And my sister is actually a nurse here at Brigham in the surgical ICU, so she ended up having her surgery at Tufts Medical Center because she didn't want to run into the people that she works with every day after surgery. So she had hers at Tufts 9 days before I had mine. We were very competitive kids growing up. So I reached 100 before she did. She was mad. She was, 9 days before I was, and I said it's because of Brigham's bariatric team against Tufts. But no, I can't say anything bad about Tufts. But for me, it was just an easy solution. For me, it wasn't a solution. It was a tool, like they said. You can't do it without hard work. Someone at work did tell me, oh, I did it the easy way when I told them how I did the weight loss surgery, and I said, you try it. It's not an easy process. It takes a lot of work. It takes a lot of dedication. For me, I've always been athletic, but I've never been a small guy. I've been overweight pretty much my whole life. This is the best shape I've ever been in my life. I'm 42 years old. I've never been this weight since I was 13. So for me, this is huge. I am running my first 5K next Saturday. I am running my second 5K 3 weeks after that, and I'm looking forward to the next one after that as well. I've never been able to run before. I started a Couch to 5K app in mid-June, and at first doing it was one of those run for a minute, walk for a minute type of things, and I kept looking ahead because I want to know what's going to happen for me in the next couple of weeks. It was an 8-week program. And when I got to like week 7, it said, you're going to run 25 minutes. It's like, there's no way I'm going to run 25 minutes. I'm going to have a heart attack on the street. But I'm running 3K, a 5K 3 days a week now. So I'm doing the 5K in a little under 13 minutes a mile. I'm running it in like 39 minutes. So it's proof positive that it takes a little bit of work, but you can do it. I didn't think I was ever going to be able to run for 40 minutes straight, but I do it now. For me, it was all about my family. I have 2 small kids. I have a 5-year-old about to enter kindergarten next week. Crazy. And I have a 2-year-old boy. For me, this was about them. This is about my wife, my love for them. I wanted to be around. I'm only 42. I'm going to be around for another 40 years, 50 years. God willing with surgery. No, I'm just kidding. But I can't say enough about our bariatric team. It is definitely integrative medicine. Without Dr. Davidson to help me fix my mind, this won't work. You have to change what's up here, not just what's down here. So if you can't get over the lifestyle changes, it's not really going to work for you. I do know people that have had the bariatric surgery that have gone back. And I've told Dr. Davidson a number of times, there's no way I'm going back. I'd rather see me like this than... I comment, I say that guy swallowed this guy, and this guy just finally came out. But it's the small things for me, and I think I've told this to the dietitians and Dr. Tavakkoli. I'm sorry. I've told this, it's the small things for me that make the difference. Being able to go into a store and actually buy a pair of pants off the rack, new concept for me. Usually it's oldnavy.com, hopefully it fits. Oh crap, it doesn't, send it back. Now I can go into any store I want, designer clothes, Lucky Brand jeans, buy off the rack, put it on, and it fits. Fantastic. That's never happened to me before, so people take that for granted. Small things like, I've never seen my Achilles tendon before, ever. I can now see my Achilles tendons. Crazy, I didn't think I had them. I thought that was part of being obese, you just lost your Achilles. But no, I actually can see them now, so it's cool. I always was very jealous of people that had those really thin ankles in the chucks with the Achilles sticking. I'm one of those people now. So it's actually really interesting. I am kind of a jokester, and I'm sorry. This is me unprepared. Yeah, that's about it. Cool. All right. I tried everything. I was going to the gym 5 days a week. In a 6-month period, I would lose 5 pounds. I would do everything I possibly could. I tried every diet under the sun, Atkins, all that stuff. I never did well with those, not until I tried the bariatric surgery. So yeah, doing everything. So trying the diet, losing 5 pounds, getting frustrated, going back up. Trying another diet, losing another 5 pounds, going back up again. So it was a yo-yo. It was definitely a yo-yo diet for me. So this was not my last resource, but this was a resource that I had known had come a long way since open surgery. My primary care physician suggested this to me 9 or 10 years ago when I first started seeing him, when I first got diabetes. And I was scared about the open surgery. So when it became laparoscopic, I kind of reevaluated and found out it was time for me to do it.
So in terms of the dietary supplements, we've definitely had patients that have used them before surgery. So as a dietitian, I like to know every single thing they've tried before surgery, and a lot of times that is supplements like green coffee bean extract and whatever's in the media at that time. And a lot of them have tried medications as well. Fen-phen was a very popular one. But I think for our patients that have over 100 pounds to lose and they're really doing this to save their life, that the modest results you might get from some of those supplements and medications is not robust enough for the urgency of which they need this surgery for their health. But we do like to exhaust other options before going right to surgery. So many patients have a long list of attempts of weight loss, and this is kind of the last resort for them. And we do have kind of a subset of a program Dr. Tavakkoli can mention where we do medical weight loss with medications.
Yeah, so I think when you think about weight management at Brigham institutional level, actually we probably don't do a very good job of it, despite the importance of this issue. So when you if you think about it as a patient who goes to see their PCP, at that point a decision is made that, okay, try to exercise or diet, or go and see a bariatric surgeon to see if you qualify for surgery, or they may send them to an endocrinologist to try medications. But once the patient enters that kind of area, there's like the real silos. So, they may go to bariatric surgery, they say you don't qualify, or the patient may feel that surgery is too risky, they're not ready for it, but there's no really alternative offered at that point to them. So what over the last couple of years we've been doing is that kind of trying to about redesigning weight care and obesity care at the Brigham. So we've started a Center for Weight Management and Metabolic Surgery. And the idea is that patients who are interested in weight management, irrespective of how, they would get referred to that center, seen by a physician expert in weight management, a dietitian. And based on their weight and comorbidities, they'll get offered choices. And they say, hey, you qualify for medication, surgery, and lifestyle. And the patient chooses, I'm really ready to have surgery, and they'll get referred to surgery and have it. But if they're not ready, they may try medications, they may try lifestyles, but they're contained within this kind of enterprise. So if they fail or if they change their mind, they can be redirected to appropriate sources rather than falling through the cracks within the silos. And I think medications has been tried. I think it's been interesting because we didn't really have that many medications to offer. Over the last, I would say, 12 to 18 months, there have been several new medications that have come on the market. And they are good, but the degree of success is really minimal compared to surgery. So you're talking about maybe 5 to 10% at best weight loss versus 60 to 70% with surgery. So I think patients who qualify different people would qualify and choose different paths depending on the degree of overweight that they have.
And have you incorporated any complementary techniques like acupuncture, or has that been talked about? How do you discuss that with patients?
So, so in terms of the center, I mentioned we have talked about having that kind of element as part of the services we offer to the patient, but we haven't actually done that, and I would love to talk to you more about it if you feel there's a role in that. In terms of our current paradigm, I don't think we really offer it to the patients or discuss it, but
I've recommended to a number of patients actually, but many of the referrals have been to places outside of the Brigham. So if we've got experts here, we're thrilled, and that's part of the beauty of coming in to see not only do we do our integration, but we can become more integrated into the whole Brigham fabric, because most of what we're aligning with are pulmonary and cardiac and endocrine and ortho and so on. So if we can get a little more of those services involved, we would love to, and we'd be happy to entertain having some folks come and talk to our whole group.
A few years ago, I referred regularly to your center, actually, to the Institute for Reiki and acupuncture. I found that was very helpful for a lot of the patients after surgery, more so 2 years post-operatively when they were struggling with other issues that might have come up. After the first year, it can be very challenging for a patient to maintain their weight loss, and other issues may come up as they're not focusing so intently on the weight loss during the first year. We like to call it the honeymoon period, unfortunately, because it does seem so easy.
In the back, please.
I don't know whether it was a slip or not, but the third speaker talked about shrinking of the liver, and what are the changes in the liver that happen because with severe obesity, can actually end up with cirrhosis from the diastatic change.
Should have clarified, we were talking about shrinking the fat around the liver. So one of our diets, the liver volume. So the diet that we put patients on has been proven in the literature to increase operative or decrease operative time, decrease operative risk. And what it is it's a 1,000-calorie diet with about 65 grams of carbohydrate that is found to reduce liver volume right before surgery. So that's why we prescribe it, and hopefully it's making a difference in the operating room.
So yeah, if I could comment on that. So I think in that picture you saw with the human body and the obesity, so liver is certainly very adversely affected by obesity. So you initially get a fatty liver that can progress, as you mentioned, to cirrhosis. And in fact, nowadays in the US, the commonest indication for a liver transplant is no longer alcoholic cirrhosis, but it's actually NASH and fatty cirrhosis of the liver. So certainly by doing the surgery, there's a good amount of evidence that the fatty liver reverses, and if you have early fibrosis, that may actually reverse as well. That's separate, a slightly separate issue to what Katy had talked about, which was this acute weight loss before surgery. And that's really just to help reduce the size of the liver. So during surgery, when we have to lift the liver up to expose the stomach, that maneuver becomes easier to do.
Other questions? Yes, in front.
To what extent is diabetes eliminated by this surgery? Or you assume you can?
No, I was type 2 diabetes, and I was not insulin dependent. I was basically weight and exercise controlled. My hemoglobin A1C was a 9.8 before surgery. I was on metformin. I believe my last hemoglobin A1C was a 5.5, unmedicated. So not just the diabetes, but my cholesterol was 217 medicated. It's now 123 unmedicated. Everything has been, all my morbidity issues have been reversed. The gastric bypass was because of the type 2 diabetes flip.
I think that's all the time we have.
Thank you so much to all of our wonderful presenters. This was just, as I said, a really excellent example of integrative medicine. I cannot commend you enough for this really wonderful presentation, so thank you. I want to first point out that our next two presentations, the next one, October 6th, will be presented by the Boston Medical Center colleagues, led by Dr. Paula Gardner. And following this in November will be Spalding Rehabilitation Network, Dr. Eric Leswitz. So we're very excited to have these, looking forward to them. And thank you again all for coming.